All right. Hopefully everyone is still with us and you had a little refresher um, and took a little break. Now we would like to welcome you back to March 26th webinar. I'm sorry, office hour. We do have a distinction there. And we would like to, with that, introduce you to our amazing guest, Logan Strouse. Logan is a data scientist for at University Hospitals, Rainbow Babies and Children. Logan is a highly skilled data scientist at university hospitals, and he is a very data-driven analytics leader. He has an impressive track record of executing, I'm sorry, uh, complete data science pipelines, and that included data integration, mining, statistical model development, and report building. Logan applies his expertise to collaborate with clinical teams to improve care delivery and enhance population health analytics. Please help me welcome Logan.
Thank you, Anna. I appreciate you for the introduction there. You are way too kind. She went ahead and gave a great little bit of a background here that, we work together. I get to work with Anna here. I also get to work with Jen and some of the other great folks here on the PPN side, including David, who I think some of you guys are aware of as well. So with that being said, we're going to kick off and do a quick little just presentation on some quality improvement and data and what we do to help improve the outcomes for our patients, and kind of give a brief background on what measures are, how you develop the measures, and what's very important to focus on whenever you're creating it. So that being said, if you want to kick us off here at the next slide, that'd be great. So for anybody that doesn't know what a measure is in quality improvement, pretty much it's a critical enabler here, as we can see, in achieving a desired goal. So you got to make sure you know what that goal is and how you're going to achieve it. And you can't improve what you don't know or what you don't measure. So it's really hard to quantitatively say if you've made a difference on something unless you're able to measure it. So that's why it's so important to focus on measures when you're trying to do quality improvement work. So, and we have another point there too as well, that it also tells the team if the changes they are making have had a positive difference in what you're trying to achieve here. So whenever we're talking about measures in healthcare and how we're trying to develop them from the beginning to the actual outcome at the very end, we focus on this thing that's known as the Donabedian framework. It starts out with the structure of care, which is the location, the place, the setting where you're at, and then you focus on the process of care. So how are you delivering that care? What type of coordination are you doing to try to provide that? And then how does that affect the health outcomes? So to give a little bit more background on the Donabedian framework and what it is, it's a model that can be used to improve and understand measures in the context of pretty much anything in this type of a setting. You got the three types of steps there you need to partake in order to see the outcome at the end. And it's ingrained in everything that we do here at UH, and especially on the quality side in pediatrics. We can continue on here and talk about some of the measures that are used in healthcare. We're going to really cover three main types, which are balancing measures, outcome measures, and process measures. But really the easiest one to understand at first when we're starting out here is balancing measures. And what are balancing measures? So think about it on a scale if you have a weighted scale on both sides. So if you make one change to the system on one part, how does that affect the other part? How do you keep those balanced? Does it become, tilted one way or the other? So just think about like the standard scale and putting weights on one side, and then that comes up, and you have to adjust it to kind of come back down that side. So how do you look at balancing measures to ensure that the change you're trying to have is positive and it's not taking away from something? So in the context of the PPN group and the EIIC, we've kind of come together and talked about a few potential examples here. And one of these examples that we're going to talk about today is the consult line, and then the number of resources if there are to meet that. So if we think about there just being one line, where somebody's calling in and stuff like that, but there's very limited enrolled providers, you might have an issue there, right? So we're going to look at if we increase the amount of consults, but you don't increase the amount of providers that enrolled in the program, potentially you're going to have a balancing issue there. You're not going to be able to meet that need. And then it's vice versa as well. You can enroll enough providers and have a significant amount, but very few consults coming in. So on the balancing side of that, there's a negative to that. If you have too many, but not enough demand. And then on the flip side of that, like we mentioned, you can have too much supply and not enough folks on the other side of that. So does anybody have any questions on that or anything they want to add, Anna or Jen or anybody else?
No, I think you summarized that pretty well. Again, I think it's just really those unintended things that happen when you try to do any kind of work, whether it's a change effort. I mean, all at work is a change effort, but just be thinking of the things that like, well, what could happen that we're not directly thinking about. But no, that was good.
For sure. And then also the group here and Jen as well has helped provide some other potential avenues to look at measures too that are related to this, and we can get into some of those later on here in our presentation. So here's our main slide here, and kind of goes over the other two measures that we're not going to get into too much detail about today because we don't want to really get too much into the weeds. We want to focus on just the high level stuff to kind of give everybody a brief taste on what we do here and kind of focus on one main measure, which is the balancing. So the other two measures that we're going to talk about here are outcome measures and then process measures. So when you think of an outcome measure, think about it as if you are the patient, for example, in a healthcare situation. So you're the voice of that patient, and you're wanting to look at it from the perspective of, how is stuff performing? What is the result? So how are they seeing it? And then, we got some examples here as well from the clinical side here at the hospital, and then also too, maybe some examples that we can look at from the EIIC side. So an example would be percentage of patients harmed. We don't want that to happen. So if you're looking at implementing a change and the outcome is, okay, what percentage of the patients were harmed by our intervention here? And we want to try to decrease that as our objective function. How do we do that, and how did that come out? Or we can look at an example here that might be a little bit more relevant to some of the grant work and the PPN stuff. So like in terms of what is our percentage of unplanned returns to the ER for mental behavioral conditions? So we can kind of think about that for a while and look at that as our outcome and what we're trying to decrease, because we don't want to have unplanned returns to the emergency room. So what can we do to prevent that? Is it going through and having more consults, making sure we're taking care of those patients, making sure they're getting the proper care. And by doing that, hopefully we decrease our unplanned returns to the ER. So, and future things like that.
I just wanted to add here, Logan, we are here looking at one of the opportunities here and where we are in Rebos, looking at the return or second suicide attempts. As one of the measures, outcome measures. So we identify the kids that are, they have came already to us, unfortunately, with this a diagnosis, and now we're looking in to see how what we can do, what steps we can take as a system, as an organization, with our partners to prevent for them to coming back with the same diagnosis. So that's one of the examples of the outcome measure that comes in mind. I wonder if anybody else has ideas that you guys are measuring with your programs. All right, we'll
I
let it
see we get the,
marinate. Now we have
yeah,
some.
as I say that, yeah, if anybody wants to chime in here at any point within the presentation here, feel free to do that. I just turned my camera on so I can go ahead and see everybody here as well. So if we can, like I say, eliminate, patients coming back for that second attempt, we can consider ourselves to be very successful here. So it can also be applied to other conditions outside of that as well here too, in terms of people adhering to their medications properly and controlling, ongoing conditions like diabetes and stuff like that. If they're able to take their medications, hopefully they don't come back to the hospital for conditions that could be treated by medication and stuff like that. So that's just another basic example there that I happen to think of. So that being said, I'm going to move on to the next one here, which is process. So this is the voice of the workings of the entire process and system. So, what are the actions that make up the healthcare delivery? So it's all tied together. Everything's a working system. So what's tied together to attain these outcomes? And then how do we address, the very important, salient key parts and steps of the system that are performing? So I know that sounds very technical, but I can go ahead and put that into some, perioperative example, and then, also to what we got here with the EIIC program. So think about an on-time follow-up for mental health treatment after a hospital discharge. So how do we monitor that process over time? Are we tracking that, we're properly having our providers reach out to the patient and making sure that they're adhering to what the advice is that we have given them, the consults, for example. And then how are we tracking that over time? We might track that with an SPC chart or a run chart and be able to watch, okay, are we following this process and staying within the range that we want to do? So when I talk about ranges and how do we measure ranges, in an SPC chart, you got your center line, and then you usually got an upper control limit and a lower control limit, and that's your band. Now, to get into super technicalities about that, we talk about one standard deviation above the mean and one standard deviation below the median or mean. But essentially, it just captures the 67% of your population that you're trying to keep an eye on, and you want to keep them within that band. So, how do you do that, and how do you watch that over time? And anybody want to add anything there by chance? Okay, I'll
Logan,
keep going.
you mentioned something, you said some SPC line, you said, and I don't know if I know that terminology.
Yeah, I just kind of used, generic terms here of an SPC chart. So a statistical process control chart.
Oh, thank
which
you.
is-
That is helpful. Okay. Sorry, my
Yep.
school, it's been a while ago.
No, you're all good. Anybody has any questions on that, you can always reach out to me too after this, and I can kind of show, people how they can implement a change and then track it over time as well. So, and again, I do have one other example in this block here. And so, it's kind of related to the first. How do we enroll more providers to the program, enabling a greater volume of patients, effectively improving our access to care and reducing readmits. So again, that's kind of tied to some of the other measures we talked about earlier and the outcome potentially too. So it's all focused on minimizing the objective function, reduce those readmits. How do we make sure that we provide the quality of care that and attention that's needed to effectively reduce that? So again, everything's kind of tied together as a system. So when you're going to do a clinical effectiveness team, which is something that we're very much huge proponents of here at our hospital, all of our measures kind of, interrelate in one way or another. They support each other. So you can see that the process measures examples that we gave support the outcome and thus support the balancing measure. So they're all interrelated, and they're all focused on trying to optimize positive aspects that increase and improve the outcomes of our patients. So, and again, just for reference down here, we have the balancing measure, and I left the consult line and enrollment example that we used in the prior slide there. So again, I can give another quick rundown what that was. So again, we looked at, how do you balance two things? I talked about the scale, and as you add weight to one side, what happens to the other? It's the same concept as that. So how do you balance that and make sure you keep an eye on what happens to the other part of the system when you make an intervention on one or a change on it? So just something to really be always cognizant of when you're looking at that. So we're developing project improvement measures. There's multiple steps that we have to go through, and the most basic thing is to always do a big scoping exercise when you're trying to develop a measure, because it'll help eliminate a lot of headaches that might otherwise happen if you didn't do prior planning on it. So You can think of the name for the measure. What is it you want to do? You want to use a description that is easily understood by your audience. So you don't want to make something that's so technical that, folks have to, really try hard to understand what you're trying to do. So make it something that's relevant to what you're doing. And then you want to define what's the objective of that measure. What are you trying to achieve with it? Are you trying to reduce the readmits, which is a great thing? And then how are you going to attain that goal? So what's the numerical target or goal? So you kind of, when you're trying to develop that part out, you look at, okay, historically, we have averaged, two readmits a day for a basic clinical condition that is very popular in the hospital, unfortunately. That has high volumes. How do we reduce that down to one or a half an admission every day? So what's that numerical target or what's that numerical goal? So once you have that, you kind of know what your baseline is and where you're trying to improve to. Is that a 50% improvement? Is that a 25% improvement? How do we get there? And then that helps inform you in your ability to refine that objective of the measure if you want to go back and do that. And then is this a outcome, a process, or a balancing measure? So again, you can reference kind of some of the other notes that I had on the prior page and where you're going with it. So
Logan, why is it important to identify in the beginning whether it's outcome, process, or balancing measure? Why do we need to differentiate? I'm sorry,
so
this might be a silly question.
You're great. No, it's
Thank you.
great here it's great to have that. So anything to continue the conversation here. So it'll kind of help you follow the right framework then. So you can kind of use the prior framework so you know what questions to ask. So when you're trying to identify the numerators and denominators, and we're going to get into that conversation actually a little bit in a few further slides. It's slightly different for an outcome, process, and a balancing measure. And if you know what type of measure it is you're looking at up front, it helps you kind of make sure you're asking the right defined questions for that. So is that kind of enough of a little bit of a rundown here, Anna, before we get into it?
Yes, sorry, I was on mute for a second. It was helpful.
You're
Thank
good.
you so much. Yes, that's helpful.
All good. So we're going to move on next to the operational definition of the measure. So again, we're going to talk a little bit more about that second part of kind of the basic information there. So this is the point where we start talking about data elements. So like, what are the things you need? Do you need a patient's name? Do you need their address? Do you need, what type of elements do you need? Their age, things like that. Those are all examples of elements. And then again, like I mentioned prior, we're going to define what the numerator and the denominator is of something. So thinking back on more basic terms of like what is a numerator and what is a denominator. It's very similar to, it's actually the same thing that you learned in elementary, middle school, and high school when you're doing division. You take your numerator and divide it by the denominator. Your denominator is your total population. So we got this entire group of people here. We got maybe 25 people on this call. And we're going to create a measure here for this entire group that we have on the call. So our denominator is going to be 25 people on the bottom part of the fraction bar, right? And then we say, okay, how many of these people on this call currently have their video on? So we have 2. So that'd be our numerator would be 2. So me and Jen currently have our video on right now. So we wanted to measure how many people are using their video on a Zoom call. This would be a perfect example of how you define a basic numerator and denominator. So numerator, again, is how many folks have their video on out of the total amount of people on the call. So 25 people on the call or 22. And us 2 have our video on, so it's 2 out of 22. So that's how you kind of define a numerator and denominator, and that can be applied to the consults and then the total consults as well, the total providers. So you want to know how many total providers are enrolled in the program. That would be an example of a denominator for any measure where you're trying to measure anything against your total population of enrolled providers. And then, just say we're trying to measure how many consults there are per provider. So you take your total consults and then divide it by your total number of enrolled providers. And you can measure then, how many consults per enrolled provider that you're getting. And we're going to get into a little bit more of those details going forward. So Jen or Anna or Alejandra, any other questions or anything you'd like me to add to this?
No, just going to pause and to see if anyone had any questions from the group.
I think Dina Dornak has a question.
I do not have a question, Logan. I think
Okay, just double checking.
Actually, no, but I think no, your explanation has been very good.
Logan, I have a question.
Yes.
You know, it's we prior to your joining us today, we've discussed several things of how do we begin our projects and base it on the QI science. So we've talked about stakeholder involvement and the needs assessment. So with that in mind, what would be your recommendation as to when should we start measuring our outcomes or our measures or our metrics in that in that continuum. Now, to add, so you have that a little bit of background. We talked about SMART aims, setting SMART aims priorly, but we do know that stakeholder identification analysis and then a needs assessment could be something that's happening in the beginning of our work, but then when should be starting to look at operational definitions of the measure? When is this an appropriate time in that continuum of the QI work?
Yeah, I would say as early as possible when you start trying to understand, you start getting, your data and you start scoping things out and you get a better idea of, what we're doing as a process or what we're trying to improve. You want to kind of define those objective measures early on, but you don't really typically physically build out the measures and look at outcomes until you get towards the end of it, after you've already done your key driver diagrams, which again, those are things that I think might have been covered earlier on that help you scope out, what you're trying to do. And then from that point, then you can build out your objective measures for your targets and then work towards, how do I measure my outcome? So does that kind of help there a little bit, Anna?
Yes, I was just thinking that.
Verbose here.
No, I was just thinking with regarding to SMART aim. We cannot really identify that M in the SMART aim without the baseline data, having identified the operational definition and basic information. Is that what I'm thinking? Am I thinking in the right pathway here?
Yeah, you can kind of go back to it. You can go
Okay.
back and revise it once you got that too. So kind of just to get
All
started,
right.
and then come back and you can revise your SMART aims and things like that.
Okay, thank you.
Yep.
It's helpful.
Deal. Okay, and make sure I covered everything on this slide. I don't mean to be running a little bit behind here, but so we talked about, the numerator and denominator, and then is this something that can be standardized across different conditions, different places, different locations? Is it applicable to other benchmarks that are out there? Because you want to use the same types of terminologies, you want to use the same types of definitions. So if this is considered a consult at Rainbow, is this considered a consult at another hospital system? So you want to make sure that you have the same definition for everything so you can compare apples to apples down the road, or as you're currently doing your quality improvement project. And that also ties in with your inclusion, exclusion criteria. So in the data where you'll collect it. So like when you talk about including, so what is that population including of people, of providers? Is it a certain type of provider? Is it a certain type of specialty? Is it mental health providers? That would be your inclusion criteria. Say you're not going to include an orthopedic provider, for example, or a cardiology provider. You don't want to include them, for example, maybe. That would be an exclusion criteria. So when you talk about inclusions and exclusions, including is very important, making sure you list down, what criteria do you need to have to be part of this group, and then what criteria do you have that would exclude you from this group? Is it not the right type of provider, the right service line, et cetera. And then same with the patients. Are we going to only look at including pediatric patients? Are we going to look at including adult patients? So are you going to exclude patients above the age of 18? So just kind of something to be cognizant of as you're, building out your measures. And then how are you going to sample this data? I strongly suggest sampling it, doing a dirty data pull to make sure what you're doing is feasible and something that can be tracked with a reliable process over time. Because one of the most frustrating things you can do is get started on something and think that it's a great idea, and it probably is a great idea, but you don't have the data to support it, or there's something different with the population that's not applicable. You have to kind of take 2 steps back and redefine your entire project. So it's always important to do some type of sampling throughout your project. And then for each measure that you do, how are you going to define, what each element's going to be measured in? Is it going to be in, time? Are you measuring time consistently across measures and across groups? If you're looking at length of stay, you got to make sure that it's going to be in days for every part of the element that you're looking at. You don't want to mix days with hours, with minutes, because then you can't really derive much meaning from it over time. So you want to make sure you continue with the standardization there. And then if the data involves making a judgment, such as late, what's considered late? Is late 5 minutes after the 5 p.m. cutoff, or is late, directly after 5 o'clock? Is there any sort of, leeway there? So that's just something to kind of keep in mind as we go through this. And then we're going to start talking about some of the other things as well here. So, when it comes to the administration portion, where is the data located? Is it coming from an Excel file that's emailed to you? Is it coming from an internal database? How often are you going to get that data? Is it going to be on the cadence of daily, hourly, minutely, monthly, bi-monthly? Who's responsible for getting that data, and how will you collect it? Is it collected in a REDCap survey? Is it collected automatically through a internal system of some type? And then how is that data going to be displayed? What graphs will be utilized? Are you going to build out something in a Microsoft Excel document and just do a up and down standard histogram or a pie chart? Or is there going to be, in some of the more, I guess I would say exotic systems like a Power BI or a Tableau, for example. So, and then what type of graphs will you make in those systems? So for a lot of the needs of, quality improvement work, it can be done in a basic Excel chart, which could be a pie chart that just shows you, it's a round thing and it has parts of the whole. You can kind of measure, your consults. And then who will make that graph? Do you have a dedicated data support member, or will it be the people conducting it themselves, or you guys? And then who reviews that graph? Is there a chain of command that has to sign off on it and make sure it's okay before publishing in a public setting? Is it going to be put on a poster board for a presentation to some type of conference? And who's going to review that data, and who's going to make sure that it's correct and that it's updated over time? So that's what some of the important things are to make sure that your project has lasting change. Is you want something that's consistent and something that can be maintained easily over time. And then what other additional information do you need? Do you already have this baseline data? And if yes, when is it and what time frame is it from? Is it relevant to today's time? Because if we go back and we look at data from the COVID period of 2020 through 2021, a lot of things have changed since then and now. You might be missing, consults from that time when people weren't going to the hospitals often then, is what they are now and what they were prior to COVID. So you got different time periods when different things happen that are extraneous. So you want to make sure that you kind of keep those things in mind, when you look at how things are going to be compared. So those are things that are demand shocks that kind of change, and shift the data and make it very difficult to, track one period over another, but you can always correct for that. And you just got to look at it with a fine lens and understand that, okay, this data might be a little bit different because this was happening in the world at this point in time, and it might have skewed this. So, we can see that at the hospital. Kids might have been getting less well child checks during the COVID period because their parents weren't bringing them to their primary care providers to get their normal checkups. And so we're kind of back to seeing more of those again, for example. So does anybody have any questions on this page before we move on here a little bit, or have any questions about building an Excel chart or anything like that? And yes, Anna, fire away. Oops, sorry, I thought you had your hand raised. I apologize.
Oh, it's okay, but I can still fire away.
Yes.
So when you talk about administration, how like what has been your experience in the hospital environment when we displaying or communicating data points with different stakeholders? What are the levels of administration, and maybe just a little bit in an overview how this is being done in a hospital environment, so the folks who are on the call here who are not in the hospital environment can have quite an like high level idea of why do we even talk about this in as far as administration and where data is located and how this brought up and to the what do we call a C-suite from from the community stakeholder perspective?
Yeah, so I guess I would just kind of say, so let me just explain it from the perspective of it really comes down to understanding your audience. And at the hospital, we have different types of audiences. So you think about your executive C-suite, and you would present to them differently than you would to a clinical group that's doing direct patient care, which is then you're going to talk different to and present a different way to your internal quality team members. And then you're going to also present differently to the community. So it's all about understanding the audience you're in, and then, what they're looking to get out of the presentation. So like an executive might just want to see some high level details on a slide or two that shows overall outcomes and overall volumes, and is something that's actionable that can be, broadcast out to further up the chain and, report out to the board and stuff like that. So you want to be very concise and clear and not get too much into the weeds whenever you're talking to, in most situations, executive level leadership. Now, if you're talking with your own internal quality team, folks that are very similar into understanding the technicalities of stuff, you can get into a little bit more of the weeds and start talking a little bit more about the statistics of something and significances of particular variables. So, and why this is important to act on. So, and then when you start talking to residents and fellows, for example, it's very similar to how you're going to talk to your internal quality team, and really how we're talking on this call, because you're trying to help them grow as individuals in their data abilities and their quality improvement skills. So you might be able to be a little bit more technical, but not as technical as you're going to be with your internal quality team group. And then, of course, when you go to the community and you're going to present something out there to just the general public, it has to be something that can be distilled down and be something that's easy to understand, and be able to explain things very clearly. So you want to say that we have seen flu cases decrease this year, down 25%, even though they were up this year. For example, in reality, you want to make sure you explain something in the basic terms, so that way folks can get value from it. Now, if I was talking to an internal quality group here about, what we're seeing with the flu and stuff like that, I say, okay, we're one standard deviation above the mean in terms of what we typically see in a given flu season. And folks would be a little bit more apt to understand what that is and be able to act on it and understand that, okay, we need to have some increased vigilance into what we're doing. So how is that there, Anna? Is there anything else I can
Thank
kind
you.
of
Thank you so much. This was very helpful.
Very good. Thank you so much. Great questions here. And like I say, if anybody else who wants to ask anything, just chime into the chat or message here via video too, so you can hop on here. So let's go ahead and kick to the next page here then. So we've already talked about this a little bit in the prior slide, so I'm not going to spend quite as much time on it this time around. But we're going to talk about the numerators and denominators. And again, this is just, I know everybody and myself included is a very visual learner. And so this kind of helps us understand exactly, what we talked about in some of the prior slides a little bit easier. So, so we got in here the numerator and denominator. We talked about the math, the division aspect here, and it's also known as a ratio. So as a part to the whole, what part of it are we talking about in comparison to the whole? So the numerator is the key measure, the small part of the whole compared to the denominator, which is, the appropriate unit of the production, the total volume of what you're looking at, total patients. And we had some great examples here from the team by Jen and Anna here that we kind of, went through before we hopped on this call today. So if we're looking at a possible ratio measure of consults completed over total enrolled providers, our key measure, our numerator, is our number of consults completed by the provider within the PMHCA program. And then our standard unit, our whole, is going to be the total, the grand group of the enrolled providers in the PMHCA program. So, and then that again brings us to our ratio measure, which is the total number of consults completed by the total enrolled providers. And then we can go back and talk a little bit here about another key measure as well, kind of, ties in a little bit to, we can use the mental health example here and just say our mental health returns to the ER here. We're going to look at our total readmitted patients divided by our total number of patients discharged. So our readmits over the total discharges would be our possible ratio measure there. So it's possible that we'll see a lot of variation and volatility with these over time, depending on the time of year and stuff like that, and some other things that we can't control outside of our scope. So that being said, do you want to kick to the next slide there? And it's going to give a little bit more of the technical background on this. So again, this is a nice little slide. If somebody wants to take like a screenshot of this, you're welcome to do it. So this is how you compute a rate, and it kind of puts everything together for what we talked about here, and it's adding another aspect to it, and we're going to call this the multiplier. So the multiplier is a very important concept that we're going to get into a little bit more of those details in the next slide. But our rate is made up of our total number of events over the denominator again, which we're talking about the total number of opportunities. So central line days, vent days, total returns, total admits, patient days. And then sometimes we add a multiplier to them, because sometimes if you would take an event that doesn't happen often, a numerator, something that's very rare, in a case where there's not many events, but there's a lot of opportunities for that event to happen, you get a number that's very small and you can't really derive much meaning from it. And so you sometimes want to add a multiplier to it. So I got an example there of, why do you look at, patient days rather than patients? And so another example of that is CLABSIs in the hospital. Any hospital system you work in, you want to eliminate CLABSIs to the best of your ability. CLABSI, in case anybody here has not heard of it, it's a central line associated bloodstream infection. It's a very dangerous condition, and we want to try to eliminate that to the best of our ability. And so thankfully it's a very rare event, but there's a possibility of it happening in a lot of different cases, a lot of different opportunities for one to happen. But because it's such a rare event, you want to compute your rate, it becomes a decimal number that it's very difficult to try to derive an understanding and a meaning from. So we add a multiplier to that. Does anybody want to add anything to that before I talk a little bit further on the multiplier here? Okay, we can continue to the next slide. So here we go. We got the CLABSI example here, and then we also got an example from the the grant side here that might be a little bit more applicable, a little bit, I want to say easier to understand or easier to apply to what we're trying to accomplish, and maybe you can apply it to what you're doing in your current work here today. So a multiplier can be 100, it can be 1,000, it can be 2,000, and what it does is it helps derive meaning. So let's look at our CLABSI example. Let's say that over the course of many, many years, you have, across many different systems, you have 205 CLABSIs for, and a total of 163,418 central line days. So that's a lot. A central line day is when a central line is placed in a patient. How many total days is that central line there? So, and then how many CLABSIs have happened over the course of that entire time? So if you take 205 CLABSIs over 163,418 potential days for one to happen, you get a decimal number of 0.001254 CLABSIs per central line day. That's very hard to kind of derive meaning from. You don't really know what it means, or at least I don't, because you think that's such a small decimal number that, you know, I guess it's not that bad, right? Because it's so small. It's less than what seems like, you know, 1% there. So it's got to be something that's very minimal. And then if something else happened here, and let's say we went up to, you know, 410 CLABSIs, you know, it would be doubling our total CLABSIs. It would be very difficult to see that, you know, that there was much of a change, because it would still be a decimal number even though it was a potential significant change. So, so you take that and you want to add a multiplier. We want to add 1,000 central line days. So you want to say per 1,000 central line days, how many CLABSIs happen? So we want to say, instead of just per 1 day, per every 1,000, how many CLABSIs happen? And you get 1.254. So that's actually saying, okay, well, I guess we get 1.25 CLABSIs for every 1,000 central line days. So if we would double that, we'd end up getting, you know, 2.5 CLABSIs per 1,000 line days if our rate went up to 410. So kind of would be a little bit easier for us to kind of track changes over time and be able to track significance. So, so an example here of our consults. We can think about 4 consults, and we got 345 enrolled providers. So if we take 4 consults and divide it by the, you know, enrolled providers, how many consults are there per enrolled provider? It's, you know, 0.01159 consults per enrolled provider. So that's a very small number. And so we want to say, okay, how do we make that, you know, a little bit more understandable? So we can take that times 100. And we get 1.159. So per 100 enrolled providers, we get 1.15 consults. So again, I think to me that makes a little bit more sense, a little bit easier for me to follow. Is there anybody that wants to add anything to that by chance?
Logan, so how would we then present this data? As far as consults, we would say that only 1.159, is it a percent or what is it? A rate? That's the rate, right? 1.159 rate of our, you know, our consultation line being used if we were to present it to our stakeholders.
Per 100 providers.
Oh, okay.
Yep. So there's one. So there's like one.
Oops,
sorry. Go ahead.
So it's like if you had 100 providers like sitting in a room, out of that 100 providers, 1.1 of them like there's consults. So, right?
Yep.
So there's like maybe one person that's doing a consult.
Correct. And so it looks like, you know, not a good allocation of our resources, essentially, I think.
Exactly. So you'd want to work to try to increase that.
Yep.
Okay.
How do we reach out and get more consults to help, you know, help this great amount of enrolled providers that we got? How do we, you know, be able to do more outreach to get more consults? So how do we encourage more consults to happen? So that'd be kind of like maybe potentially your action. I want to increase my rate from 1.159.
Like,
Yep. And that could be per day, or that could be per week, or per month. In this example, we just kind of left it vague, so that's a great question, Gabby. So we could add that as well. So per 100 providers per day, we could add that on as well. Is another example of adding a multiplier to that too. So great questions, everyone. Okay.
And this is Jen. So for those who might already be doing consultations, this is a really good exercise to push your data through. Because again, I think it can give you another lens, especially around quality improvement efforts, to maybe pinpoint like, hey, we have a relatively low number of consultations happening, even though we have 100 plus providers in our program. It gives you just more data to bring back to your leadership to be like, okay, what are some different interventions that maybe we can put in place to help increase that number? Or do they even need us? So that's how you can use that.
Logan, one more question. In the organizations, besides hospital, of a specialist data analysts that do this kind of work that can assist a team in such calculations and decisions making process. Are they usually, I'm looking if somebody's looking to gain in a help or solicit help from someone, who should they be asking to help with this process? Is it data analyst? Is it a statistician? Who could help us with
Great.
this?
Great questions there. So I think it depends on the organization. So like in ours, it would be any of the data analysts on our team here. You could ask a biostatistician, somebody that's in informatics as well, potentially. There's a lot of different folks that might be interested in this information and calculate these things for various studies and things. So like David with the PPN looks at this type of information as well. So that'd be another example of somebody that might be able to help too. But really, I would say any sort of analytics department or a quality department should be able to help you with that. Really, if you have a good, a well-established quality improvement program at your hospital, I would.
But if you don't, who can we go to? Can we go to nearby universities and solicit this kind of partnership, or on the community out there? If we are to discover more folks joining the teams in different teams and different parts of the United States.
Yeah, I would say, frankly, maybe somebody in academia at a local college or something could help out, but you could also just Google it as well. There's good resources out there too on StatQuest and things like that. They're great resources, and we could, of course, kind of point you in the right direction on some of that stuff there too.
Okay, well, thank you so much.
Yeah, so great question. And yeah, I mean, some med students that might have taken quality improvement as part of their curriculum might be familiar with it as well. So great points there, everyone. Yeah, so I think we're kind of getting up against the cutoff here soon. But Jen, did you want to, as part of our live activity, did you want to still continue with that today, or talk about the two examples that we have here that you had found as well, and kind of work through that, or?
Sure. I think before that, just because I know people might need to hop off, we do have a quick evaluation poll. So I'm going to pull that up real quick and give folks a minute or two to complete that. And then for those who can stick around, we can definitely do the activity. So I am going to pull up the poll. And if you don't mind completing that.
Yes, we can see it now.
Is it showing up on everyone's screens? All right, you see it, Anna?
Yes, I can see it. On the third question, you have to click on the underline answer, and they will give you an option to type in the answer. So please do that. It's important for us to plan for future different activities. You appreciate you taking the time to help us out.
thank you for the also the feedback, and anyone that went ahead and also helped contribute to our presentation today. That was very helpful. So anytime we get folks talking back and forth, it helps increase the dynamic and effectiveness of a presentation like this. So thank you.
We appreciate it. We still got some answers trickling in, so I'll leave it open for another 60 seconds.
Well, maybe a little bit more because the last question is a type in. So it might take people a little bit more time to actually type in the answer rather than answering yes, no, and other 3 options there. So let's give it a little bit more time.
Sure. Well, people are completing it too. If you're done and you have any questions too while we're waiting for folks, feel free to chime in or drop them in the chat. Words are hard today.
Yeah, I'm tired. Sorry. It's the weather here in Cleveland. It's like, it's cold, it's rainy, it's dark, it's not spring weather. So it does not help.
No, it's the worst. It's the worst season.
Wait a minute, I have to say something. Snow is the worst. Rain is drivable. So
Yeah.
I know it could be better. We could have a sunshine, but we don't have snow on the ground. That's a good day.
Thank you, Anne. Thank you, everyone. Thank you, Gabby. Wow, we are jealous of you folks down in Texas. That sounds really nice.
It's very beautiful. My dog keeps wanting to go outside. I don't blame him.
Yeah.
I know folks
Well,
are
who knows how it's going to be in Cleveland with global warming in a few
North
years.
Carolina. Nice.
Yes, they have nice weather today.
yeah, seriously. I'm
We had
curious.
60 yesterday. We had 60, what, 66 yesterday? At least
We
down where
did
I'm at.
have, yeah, we
Nice.
had over 60 yesterday. Yeah, it was a nice walk outside. Jen, you go ahead. I think you were going to mention something.
I was going to ask, so I know that for PMHCA programs, you all have performance measures that obviously are dictated by HRSA. I'm curious though, like outside of those performance measures, we've had some feedback from folks who are doing ED expansion work, who have asked kind of like, well, how do the current performance measures like relate to the ED work that we're doing? I'm curious if anyone's kind of had similar thoughts, and if so, or maybe not, like what specific ED measures are you looking at outside of your performance measures, if you are there yet? And if you don't have any, that's okay.
We want to folks put it in the chat or just unmute and
You can
speak
unmute,
up?
you can put it in the chat. If you're not 100% sure, that's totally fine too. Thanks, Anne.
Mhm.
All right. Well, I see we've stalled out on the question, so I think I'm going to end it. Oh, never mind. We just got a 10th. All right, I'll leave it open for a few more seconds.
About to say, do we just want to kind of leave this last part open here for questions and things like that, maybe?
Yeah, I think so.
Okay.
While we're all hanging out, I'll keep those up there as well. Now, it looks like a lot of folks are still in the beginning phases of that work. And truth be told, so are we. You know, we have some ideas in our mind, but a lot of what we're trying to look at this year and, you know, hopefully next, we'd love to explore if there are ED specific considerations that we would want in terms of performance. So it's going to be a lot of what we're looking into this year.
Well, and hopefully be able to find some commonalities with those pathways we talked earlier about early in the very beginning at 3 o'clock presentation, and to see how we can again, as Logan described, identify those measures and then hopefully start benchmarking some of the great things that we all strive to do. So I think that's one of the most exciting things for me this year. So looking forward to that.
Well, I think it'd be interesting information too, based on the setting. So PMHCA originally started out as primary care. Number of consultations, is clearly a measure for that work. Those performance measures are, duplicated across school-based health centers as well as EDs. But like in the ED setting, if there's low consultation numbers, like, does that mean that the program is not as effective, or is it simply because consultation, in the ED is not the preferred method of intervention? Maybe it's something else. That's something like we don't really know yet. But yeah, to your point, Anna, creating some maybe more general measures that we could point to, saying like this demonstrates, more successful intervention with EDs on, say this end versus just pure consultation. We don't know that yet.
Mm-hmm. Yeah, absolutely. Great points. Mm-hmm.
Data. All right. Now I think we've stalled out, so I'm going to end it.
Yep. If anybody has any questions, feel free to reach out to Jen or Anna, and they can reach out to me. And I don't mind having a call or an email with anybody or a Zoom conversation. So, again, like she mentioned, a lot of my work here is the quality improvement side. That's what I do here. Overlaps with the primary care institute work, and I do teaching for the case fellows and things like that here as well. So we kind of give them a very similar presentation to this, maybe a little bit more technical, because they already have gone through quality improvement training and things like that. So like I say, I look forward to being a resource here for anybody that needs it.
Well, thank you, Logan. We really appreciate your help today
Yep.
and joining us. We might call you back for more opportunities.
Oh boy. Okay, thanks,
So
Anna.
get
Take care,
ready.
everyone.
All right, have a good one. And
Yep.
then folks, we can hang out for a few more minutes. So if there are any questions, we can probably stop recording at this point. And